GERD is extremely common in people with EDS or other connective tissue disorders. The connective tissue laxity leads to a weakened lower esophageal sphincter, and we can get these hiatal hernias, which is when you have like parts of the upper parts of the stomach actually coming up into the chest. Welcome back, every Bendy Body, to the Bendy Bodies podcast. I'm your host, Dr. Linda Bluestein, the Hypermobility MD, a Mayo Clinic-trained expert in Ehlers-Danlos Syndromes, dedicated to helping you navigate connective tissue disorders and live your best life. In today's Office Hours episode, I'll be answering some of your most pressing questions. Pros and cons of wearing a cervical collar to surgery, nitrous oxide, MTHFR, and EDS. CRPS, EDS, and MCAS. That's a lot of acronyms. We'll explain what those are later, of course. Specific surgeries with EDS, and so much more. But first, I want to introduce two amazing people to you. If you're watching the video, you're going to see some new faces here. We have two of the human content producers joining us today, Tessa and Shanti. We thought it would be fun to give you a little behind-the-scenes look for this Office Hours episode. So they'll be popping in to read some of your questions and to keep things rolling. Tessa and Shanti, thank you so much for being here.
Thanks for having us.
Thanks for having us, Linda.
It's a little scary to be in front of the camera. This is new.
Yeah. I think it's great because I don't know that people realize like how many people are involved in putting this together now. So I think it's really cool for them to get to see some of the faces and, make that connection. So I'm super excited. Be sure to stick around until the very end so you don't miss our special hypermobility hack for the day. As always, this information is for educational purposes only and is not a substitute for personalized medical advice. Here we go. Okay, so today we are going to be covering some listener questions. And Tessa and Shanti, if you want to read some of these questions, that would be fantastic. So I don't know, Tessa, if you want to start with the first question and then we can discuss it.
Yep, absolutely. So the first question is from Adele, and she's talking about local anesthetic resistance and failed nerve blocks. She says, I'd love it if you could discuss the phenomenon of hypermobile persons being resistant to local anesthetics. I've had terrible experiences where a nerve block that was supposed to control post-surgical pain failed and local anesthesia for a core breast biopsy failed. My dad had problems getting numb for a tooth extraction and had to switch to IV propofol. What do we know about this? What should people with hypermobility do about it? It makes many medical procedures for me super scary. Doctors and dentists should know about this a lot more than they do.
Yes, that is such a fantastic question and such an important topic. And I have to confess, as an anesthesiologist, before I started doing this work, if you told me that local anesthetics sometimes fail, I'd be like, no, they work every single time. But now I know that that is absolutely not true. Local anesthetic resistance is an absolutely real phenomenon. Many people with EDS and HSD report that when they go to the dentist and they get numbed up, or if they get an epidural or a lidocaine injection, it often takes longer to set up. It doesn't work or wears off faster, or they need more medication. This is not psychologic. It's not exaggerated. And we did talk about this a lot with Dr. Audrey Kershaw because she's an oral surgeon. So, of course, she's using local anesthesia a lot. So I urge people to check out that episode as well. And there are biologic mechanisms at play here. This is not, an anxiety thing. There's connective tissue differences that can alter the diffusion of the anesthetic through the tissue and reduce local concentration at the nerve endings. There's also sodium channel variants, like the one called SCN9A polymorphism. And we're going to talk more about that in just a little bit because that's actually super important when it comes to persistent pain. And that can affect the anesthesia binding and nerve membrane excitability. We can also see things with altered blood flow. We can see abnormal microvascular structure and autonomic dysfunction, and these things can change absorption and metabolism of local anesthetics. Also, increased nerve density or sensitization in some connective tissue patients may lead to atypical pain signaling. There's also pH differences in tissues that can happen due to chronic inflammation, and local anesthetics are dependent on having the right pH in the tissues. So if you have that or mast cell activity that also contributes to inflammation, that could reduce anesthetic efficacy. What are some things that you can do about this? Okay, first of all, communicate early and often. Always tell your dentist, your surgeon, your anesthesiologist about your diagnosis, and in particular, about your previous anesthetic experiences. So if you've been to the dentist multiple times and they've tried to numb you up and it doesn't work, make sure that they know about that. Also, we can use multiple and also alternative techniques. So sometimes we can combine different types of anesthetics, like we can use lidocaine and bupivacaine, or ropivacaine or mepivacaine. These are all different local anesthetics. Sometimes that can improve results. Sometimes adding something called bicarbonate that can also increase tissue penetration and help give us better results. If we use ultrasound guidance, if we're doing regional blocks, like a femoral nerve block or a popliteal block or a stellate ganglion block or an interscalene block, these are all different peripheral blocks that we do. And if you're using ultrasound, it helps you to get the medication more precisely in the exact right location, and that will improve precision and outcomes. Also, sometimes you just need to take more time. So one time that I went to the dentist, they came back and checked, and it was like, "Nope, not yet, numb yet, not numb yet." And if it can take a really patient dentist to keep coming back and checking and waiting some additional time, but sometimes it just takes longer, and you don't necessarily need more. Also, epinephrine-free formulations can be better for some patients that have dysautonomia or POTS, because sometimes that uptake of epinephrine into the bloodstream can cause, extreme tachycardia and increase our anxiety and make us feel really crummy. I would definitely recommend that people document what does and doesn't work, especially if you find something that does work and you find a method that was successful, make sure that you document that. If you're a clinician, make sure that you validate your patient. Don't assume that failure is anxiety or that they're exaggerating. You should expect variable responses, even within the same patient at different times or different tissue sites. The pH of our body changes at different times. It depends on how hydrated we are, et cetera. You also want to consider different anesthetic choices, buffering, and how much volume you're using. You could consider adjuncts like clonidine or dexmedetomidine so that you can get some prolonged analgesia that way. And then I also want to talk a little bit about this SCN9A gene. So it encodes the NaV 1.7 sodium channel. We're going to get a little geeky here for a minute. This is a voltage gated sodium channel that's critical for pain signal transmission. And it's really important because it can cause gain of function mutations, and these can cause pain syndromes such as erythromelalgia or paroxysmal extreme pain disorder. So if people have paroxysmal extreme pain disorder, they're going to have extreme pain without much in the way of findings. And it's because of a genetic mutation or genetic variant. So we can have congenital insensitivity to pain. So we suspect that there are also polymorphisms in addition to these mutations that may contribute to local anesthetic resistance or atypical pain sensitivity. So you might have EDS contributing to some changes in how you perceive pain, but you could also have this SCN9A gene. So, yeah, just wanted to make sure to mention that. I'm going to mention a little bit more about primary erythromelalgia. This is caused by, like I mentioned, the gain of function mutation in this gene, and it makes pain signaling nerves fire too easily. People who have this get burning pain, redness, and warmth in their hands and feet that's often triggered by heat, exercise, or stress. And you can see right away how this could be confusing with mast cell activation syndrome because people who have mast cell activation syndrome get redness, swelling, inflammation, pain, and also is triggered by heat. So there's clearly some, overlap in presentations here. These symptoms can be severe and disabling, and patients often seek relief by cooling the affected areas, which can also lead to tissue injury if you overcool the tissues. So there's a lot of overlap here. Some people with EDS or dysautonomia report erythromelalgia-like episodes, possibly due to similar small fiber nerve problems rather than a full SCN9A mutation. And then let's just talk very briefly before I go on to the next question about paroxysmal extreme pain disorder. This is another gain of function mutation that can lead to sudden, severe pain attacks in various different parts of the body. Attacks can be triggered by defecation or pooping, cold, or even emotional stress, and sometimes are accompanied by flushing or autonomic symptoms, which of course is again confusing because that has a lot of overlap with mast cell activation. So we can see this hyperexcitability of pain fibers, but with different anatomic distributions and triggers. All right. So these are just important things for us to be thinking about when it comes to people who have this, reduced effectiveness of local anesthesia. Do you possibly have one of these other things that accompanies that problem? So thank you so much for reading that question. And I think we have some more.
Can I ask a personal question, relevant question as you're talking about this?
Yes.
Um, I'm so curious about, and I think you've talked about this in a previous episode, but I'm so curious about the effect that anxiety has on the efficacy of anesthesia because I went to the dentist. I had two dental surgeries, and the first surgery they gave me a dose of local anesthesia and I couldn't feel anything. It was perfect, but something went wrong in the procedure and it made it so
Mm,
that in the second dental procedure, I got the same dose of anesthesia, but I was coming in very anxious. I was like shaking. I had barely eaten. I was just nervous for it and I swear I could like feel everything and I was in immense pain the whole
mm,
procedure. And I'm
mm.
just wondering, like, is that a myth that anxiety affects anesthesia?
That's a great question. I love that question. Um, Definitely, anxiety affects the way we respond to medications in general, local anesthetics, sedatives, et cetera. And so I can definitely see where that could be the case. And, if you're more anxious and like you said, you were barely eating anything, maybe you were more dehydrated, maybe your pH was different, going into the whole procedure. So that's the acid-base balance in our bodies. So if you are not as well hydrated, then that's going to affect that. So I can definitely see where that could be the case. Plus, if you're more anxious and your HPA or your hypothalamic pituitary axis is like more turned on and activated, then you're going to have a difference in the neurotransmitters that are active in your body. So I can definitely see that being the case. And I can give you another fascinating example that's very similar to yours. I actually anesthetized for cataract surgery somebody that I knew very, very well. And it was funny because, we have two eyes, right? So most people have one cataract surgery than the other one. And I know you guys know a lot about ophthalmology because of Dr. Glockenfeckum. Did I say that right that time?
Mhm.
Close enough.
Yeah.
Okay. And so I know that you guys know a lot about ophthalmology. But anyway, so I was going to be anesthetizing this person and they really, really wanted to have a general anesthetic. And I was like, no, 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 no. We are not doing a general anesthetic. That is going to be more risky. But we're going to give you sedation. But she really didn't want to remember anything. So I had this plan and I did my plan and it was great. And she was super happy. She was like, I don't remember anything. Like the sedation was perfect. So when she came back for the second eye, I literally looked at my anesthesia record like it was a recipe. And I was like, okay, I'm going to follow the exact same thing. And guess what? She remembered everything.
Ah,
So,
so what's the difference? What
so
happened?
I don't know. I don't know. Our bodies are just different from one day to the next. We can respond one way to a medication one day and differently the next day. We recorded a podcast episode yesterday with both of you. And I don't know if you remember that I was like so itchy during that podcast episode. And I've been dealing with this spitting stitch, which we're going to talk about at the end briefly. For the hack. But anyway, so I took some diphenhydramine or Benadryl. And every once in a while, when I take Benadryl, I get this like dystonia, like just weird reaction where I cannot stop moving my body. And I get in bed and my husband is like, stop moving around. You're driving me nuts. But I don't get that all the time. So, so our bodies definitely respond differently on different occasions.
That's so interesting. Yeah, as a patient, I always just want to like put all my trust in the hands of the doctor and in the hands of medicine. And I'm like, I hope it just works flawlessly every time. But this is the reality of it is that our body responds differently on different days.
Yeah,
And
and I think I,
it's a
I
great
think an
point.
important point there too is you're probably not ever going to be overhydrated. So if you go in for a procedure and we normally tell people nothing to eat or drink after midnight, and your surgery might be in the afternoon. Well, the reason why we do that is because we've experimented. Like in my group, my anesthesia group, we would experiment with telling people, you can have some clear liquids or even a light breakfast If you were having surgery at like 4 in the afternoon, you can have a light breakfast so long as it's before, let's say, 8 a.m. So that way you have like an 8-hour window. Well, we were in Wisconsin. People would come in and they'd be like, yeah, I had a hamburger, French fries, a couple 2-liter bottles of soda. And we're like, that's not a light breakfast. We meant like a piece of toast. So clear liquids, generally speaking, you can have up until 4 hours before the surgery. Definitely talk with your surgeon. Clear liquids are things that you can see through, that you could read like a newspaper through. And also black coffee. Black coffee is also a clear liquid. Something like Jello, broth. I feel like a lot of times we err on the side of such long NPO, or nothing per mouth, nothing per os, is the Latin term for it. But I feel like we err on the side of such long, long times that then people come in super dehydrated, and that doesn't serve them well, and it makes it harder to get the IV in and things like that too.
Interesting. Okay. Note to self. I will be hydrating before any surgery.
Yep.
I know
Yep.
we also had a listener question come in actually about a surgery that went wrong. Can I read it out to you?
Sure.
Monica writes in, I was recently diagnosed with hypermobile Ehlers-Danlos by a physical therapist who helped me understand how much it's affected my health. Before that, I had surgery for GERD and a hiatal hernia, but it failed almost immediately. The hernia came back and my symptoms got worse. I suspect my tissues didn't heal properly because of EDS and that I developed MCAS as a result. I'm in touch with surgeons who specialize in GERD, and they're eager to do a revision. They think that the original surgery was not performed correctly. The surgeons don't seem to take EDS seriously enough, while my physical therapist is encouraging me to wait on any more surgeries. With severe GERD and advanced esophagitis, I'm at a loss. What's your experience or advice on fundoplication and GERD surgery for HEDS patients?
I'm super excited to tell you about the Bendy Bodies Boutique. I am so proud of our fierce styles and flexible designs. These are created by hypermobile artists for hypermobile shoppers. There are so many fun items, from clothing, accessories, home goods, and my favorite are the bags. I especially love the Weekender tote with one of the EDS Tough designs. Whether you're shopping for yourself or someone you love, there's so many options to choose from. A portion of the proceeds goes to support EDS nonprofit organizations. For more information, please visit bendybodiesboutique.com. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube, and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. So I love this question, and I love, Tessa, that you picked out this question, because I've actually had a Nissen fundoplication for severe GERD. Mine just came out of the blue. All of a sudden, one day, you're supposed to have the sphincter at the bottom of your esophagus, and all of a sudden, one day, mine just decided to quit. And I had outrageously severe GERD. I would bend over and food would come up and things like that. So this is a great question. Affects a lot of people. GERD is extremely common in people with EDS or other connective tissue disorders. The connective tissue laxity leads to a weakened lower esophageal sphincter, and we can get these hiatal hernias, which is when you have like parts of the upper parts of the stomach actually coming up into the chest. And also, if people have dysautonomia, for example, POTS, and or impaired gastric motility, that causes slower emptying, and that can contribute to reflux. We know a lot of people with these conditions have gastroparesis or delayed gastric emptying, and that can make the symptoms worse. Also, coexisting mast cell issues can also mimic or worsen reflux symptoms. You can get a lot of chest pain, epigastric burning, and throat clearing. I had so much chest pain multiple times before I had my Nissen fundoplication. I thought I was having a heart attack. Um, I I really, really, on multiple times, I was in my early 30s, and I really thought I was having a heart attack. So things that you want to consider before having surgery, and this is for anyone who has severe GERD, and maybe they're talking to a surgeon, not necessarily for Monica. We're going to get to Monica's question about a redo in just a minute. But things that you want to have done beforehand. You want to for sure have an upper endoscopy, and they're going to look for things like esophagitis, Barrett's esophagus, and how big the hernia is. Barrett's esophagus is a condition where you start to see abnormal changes on the pathology in the esophagus, and those people who have Barrett's esophagus are at increased risk for esophageal cancer. And you do not want esophageal cancer. Not that you want any cancer, but esophageal cancer is a really bad one. So if you have Barrett's esophagus, your recommendations are going to be different than if you don't have Barrett's esophagus. So just keep that in mind. Definitely ask if you had biopsies or not, and if so, did they show any signs of Barrett's esophagus? Oftentimes, if they do, then they want much more frequent monitoring and keeping a much closer eye on that. Another thing that you need to have is esophageal mammometry to check for peristalsis, which is really, really important for choosing the right kind of wrap in order to keep things in the stomach, basically separate from the esophagus. This is not a fun test. I had to have this, of course, before I had my surgery. They put a probe down through your nose or your mouth, I can't remember which, and you're wide awake, and they have you swallow and do all these different things, and it was not fun. But it's very important that they can get an idea of the strength of your esophagus, because they don't want to put this wrap in place at the top of your stomach near the bottom of your esophagus if you're not going to be able to push food through, because now you're going to have a different problem. They also often do 24-hour pH or pH impedance studies to confirm whether you have pathologic acid or non-acid reflux. Gastric emptying studies are really important to have if you have early satiety, nausea, or bloating, because unrecognized gastroparesis can definitely sabotage outcomes. You also want to review your medications, because maybe you're taking something like opioids or anticholinergics that can worsen reflux or motility, and maybe changing some of your medications might help. You also want to optimize non-surgical management, like elevating the head of the bed, avoiding late meals, using smaller portions, limiting alcohol, mint, chocolate, and high-fat foods. Sometimes you want to trial proton pump inhibitors, but ideally those would be taken only for a short period of time unless you have EOE, which is eosinophilic esophagitis, or if you have Barrett's esophagus. There's some other indications as well to talk to your gastroenterologist about. H2 blockers like famotidine can be very helpful. And also, walking around after meals and bedtime can really help as well. Definitely want to treat constipation and consider medications that can accelerate gastric emptying. Those are called prokinetics. Also, treating MCAS flares with things like H1 and H2 blockers, cromolyn if appropriate, can be very helpful because that can masquerade as reflux. If you are thinking about surgery, you want to consider things like tissue fragility and hernia recurrence risk, because these are higher in EDS. So you want to choose a really experienced surgeon in foregut surgeries like this. So there are also multiple different ways to do wraps. They can do partial wraps, or they can do a full wrap, which is the Nissen fundoplication. That's the surgery that I had. And I think I have a picture of that. I'll see if I can dig it up, and we can maybe put it in the show notes or on one of the social media posts if anyone's interested. There's also a procedure called the Lynx procedure, which is a magnetic sphincter, which is an option for selected patients that have normal motility and maybe have a small or no hiatal hernia. But the data for that in EDS patients is limited. There's also details to consider for repairing the hiatal hernia itself. And you can consider crural reinforcement, which is the part of the diaphragm where the esophagus, comes through. The use of mesh is a little bit controversial in EDS because of healing and erosion risks. And also, a lot of us do not like foreign bodies, and mesh is a foreign body. So sometimes we reject these things, as we're going to talk about later with sutures and my forehead. Another thing to expect after a full Nissen fundoplication is that burping or vomiting may be difficult. And after I had my Nissen fundoplication surgery, I was having so much pain, even weeks later, and I did not know what it was from. And I was I was working in the operating room at the time, right? So I was seeing surgeons all day, every day, including my surgeon who operated on me. And I said to him one day, as we were literally like passing in the hall, I'm like, why am I getting so much pain from time to time? And another surgeon was literally walking by. They were partners, or maybe they were walking together. And my surgeon didn't say anything, but the other surgeon was like, oh, you have gas bloat. And I'm like, what? He's like, you're getting gas in your small intestine that normally you would burp out. But because you had this Nissen, because you now have this tight wrap around your esophagus, you can no longer burp that air out. And so it can be really, really uncomfortable. So the interesting thing is my Nissen did loosen. It's not completely failed, but I did throw up a few times. And my surgeon initially was like, "You can't throw up. That's impossible." Oh, yes, you can. If you have enough of a need to throw up, you can throw up even with a Nissen. So I don't know if my Nissen partially failed because of the fact that I, vomited a few times. I got food poisoning and also probably motion sickness, or is it because of my connective tissues? I'm not sure which. But right now, knock on wood, I'm in that sweet spot of like my GERD is perfectly well controlled. I'm not taking a PPI, like omeprazole, and also I don't have gas bloat. So I feel really lucky. I have like just the right amount of, coverage down there. Some special EDS considerations in the perioperative period include positioning. So we want to be thinking about joint protection. We want to be thinking about our necks, which we're going to talk about later when it comes to, do you wear a cervical collar or not? If your skin tears easily, be sure to let them know about that. Or if you have any problems with adhesives, we want to be careful how we're securing IVs and airways because a lot of people are reactive to tape. We mentioned already about local anesthesia resistance. So sometimes multimodal analgesia is important. And also want to think about things like POTS and dysautonomia. Do we need to have more fluids? Do we need to get mobilized, slowly? Do we need salt or compression postoperatively to reduce orthostatic symptoms? We also want to be thinking about wound healing and bleeding. Really, really meticulous technique is important for this, and discuss scar care and activities ahead of time with your surgeon. In terms of the postoperative course, dysphagia or difficulty swallowing is very common. I remember I was on a clear liquid diet for 2 weeks. And then after that, I could start like slowly progressing to foods. And I don't know, I had my Nissen, gosh, 20 years ago. It was a long time ago. So now the requirements might be different. But at that time, clear liquids for 2 weeks and then slowly progress on your solids. But I remember like it was yesterday being in a restaurant. I ate meat at that time and I ate a hamburger and I could feel this chunk of the hamburger stuck in my chest. And it was so painful. So, so painful. So when they say advance slowly from liquids to soft to regular foods, because you have this tight thing now and it doesn't function like your normal esophageal sphincter does. So if you have fundoplication surgery, if you have one of these GERD type surgeries, just remind yourself to take it really slow and, progress very, very intentionally. You want to watch for things like persistent dysphagia, uncontrolled gas bloat. And one of the tricks that this other surgeon told me was lay on my back and put with my knees up to my chest and roll side to side. And what that does is it helps move things through the small intestine. So probably a good hack anyway, just in general for, getting your GI tract to move. But in particular, that really helped me when I would get these gas bloat pains. So it's interesting because my surgeon was like, I don't know. But this other surgeon says, I think I know what that is, and this is what you should do about it. So I got lucky that I asked that at the right time. Um, Chest pain is quite common, as I mentioned. Some people do get regurgitation. Weight loss is quite a common phenomenon. Sometimes people get, the wrap might be too tight. It might slip. You could have an unrecognized motility disorder or a recurrent hernia. We already talked about gastroparesis, but make sure to address that. It's really important. Otherwise, we can get reflux-like symptoms, even with a quote-unquote perfect wrap. So who tends to do well versus who tends to do poorly? Better candidates are people who have objective evidence of reflux on pH testing. They're responsive to PPIs but intolerant. They have normal or only mildly impaired motility, smaller hernias, and have realistic expectations. Higher risk for suboptimal outcomes includes people with severe hypomotility, significant gastroparesis, uncontrolled MCAS, large paraesophageal hernias with very lax crura, which again is that area, it's a crura means cross. So it's the part of the diaphragm where the fibers cross each other, or prior foregut surgery. So again, like this person's asking, if you're having a redo surgery, it's definitely, higher risk and less likely to have good outcomes. Some questions that you could ask your surgeon include, do I have proven reflux on pH testing and what's my motility like? Given my motility, would you consider a Nissen or a partial rep for me? How often do you operate on patients with EDS and other connective tissue disorders? And I would also ask specifically, how many of these surgeries have they done? How will you minimize recurrence with my tissue laxity? Will you use mesh, and why or why not? What is the plan if I have dysphagia or gas bloat after surgery? And how will POTS, MCAS, EDS, HSD affect anesthesia and recovery? So, in conclusion for this, and then we're going to address about this particular person that's looking at a redo. But if you're looking at a first time surgery, it's very important to diagnose the GERD very precisely, tailor the operation to the person's motility, and manage expectations. A partial fundoplication or optimizing your medical and motility care may outperform a one size fits all Nissen fundoplication. Okay, so let's talk a little bit about when a Nissen fails. So failure can mean persistent or recurrent reflux. It can mean gas bloat, dysphagia, or RAP slippage or hernia recurrence. In EDS, a number of things can contribute. Tissue fragility, poor collagen integrity, or weak crural support can greatly increase recurrence risk. Also, if you have high intra-abdominal pressure, you can imagine the higher the pressure is inside your abdomen, the more that's going to want to push things up into your chest. So if you have bloating, constipation, chronic cough, vomiting, etc., that further stresses the repair. Other things include unrecognized motility disorders or gastroparesis, as we talked about already. When it comes to a recurrent problem like this, repeat diagnostic workup is essential. Probably an upper GI contrast study like a barium swallow. You're probably going to have another EGD, more mammometry, probably more, impedance and pH testing, maybe another gastric emptying study. You always want to confirm if it's a technical failure or a functional failure. A technical failure would include like a slippened or a loosened wrap, and a functional failure would be dysmotility, hypersensitivity, or MCAS. Some of the common failures in EDS include hiatal hernia recurrence due to crural laxity or poor suture hold, wrap disruption or migration. Too tight or overcorrection can cause outflow obstruction, dysphagia, and gas bloat. Underlying motility disorder, or mast cell activation or visceral hypersensitivity that can mimic reflux despite normal studies. I had an EGD a number of years after my Nissen fundoplication. I was having problems with chest pain still. Knock on wood, now I've been really good for quite a few years, but I had a period even after my surgery where I wasn't doing well and I was having chest pain. And basically after I had the study, and they were like, it looked perfectly normal other than the fact that your wrap is a little bit loosened. And they said you have visceral hypersensitivity. I think a lot of people take this personally and they're like, oh, it's a character flaw or something like that. When we have all of these pain signals coming into our nervous system adapts by actually producing more of these neurotransmitters and like looking for pain. And this is called central and peripheral sensitization. So I definitely have that. Low-dose naltrexone, as I've talked about a lot on this show, can help a lot with central and peripheral sensitization. It's one of my favorite hacks for that. Okay, back to this person's particular question, to Monica's question. First, we want to optimize non-surgical management. We want to adjust our diet and meal timing. We want to do small, frequent meals and avoid gas-producing foods. We want to treat underlying gastroparesis with prokinetics. Consider pyloric Botox or something called GPOM. This is a type of surgery that can be very helpful for gastroparesis. And Shanti has been trying to chase down one of the biggest GPOM surgeons in the country. So we keep trying to get him on the show. If you happen to know of another GPOM surgeon, let us know, because we want to discuss that, because gastroparesis is such a common problem with EDS. And GPOM can be really, really helpful. We've gotten some great reports on that. You want to manage MCAS with things like H1, H2 blockers, cromolyn, quercetin, luteolin, etc. You want to address POTS and dysautonomia for improved GI motility and tolerance. And also sometimes image-guided dilatation can help if the wrap is intact, but if the wrap is too tight. Endoscopic revision techniques might be an option for those that have partial loosening or slippage. If you are considering a reoperation, a redo fundoplication is technically complex and is going to be high risk in EDS due to friable tissue scarring and higher rates of recurrence. You want to consider the possibility of a partial wrap for dysphagia or poor motility. In select cases, taking down the wrap or considering a Roux-en-Y conversion can be helpful for severe recurrent cases of reflux or obstruction. You definitely, in this case, want to seek out a high-volume surgeon who's doing lots and lots of foregut surgeries that's familiar with connective tissue disorders. And we're going to have a list later of questions that you want to ask your surgeon beforehand so you can get a sense of how familiar they are with EDS and HSD. Avoid mesh reinforcement if possible, and if used, select biologic materials because of erosion risk. You want to collaborate amongst the members of your team: GI surgery, anesthesia, nutrition, pain medicine, and mast cell specialists. You want to consider prehab and postoperative care, including wound healing support. Okay, so a failed Nissen does not mean you did something wrong. Tissue fragility in EDS often plays a major role. We don't want to rush into revision. We want to get objective testing and address motility and mast cell issues first. Advocate for yourself. Find surgeons experienced with EDS or complex foregut redo surgery. You want to keep detailed notes on your surgical reports, imaging, and what has and has not worked for you. There's a few episodes where we've discussed similar topics on Bendy bodies, and we'll link those in the show notes. Okay, Monica, I hope that helped answer your question. And boy, did I get long-winded there. I'm having so much fun with this that I think I got totally out of track with time. And I know y'all are probably getting a little exhausted. So I think we're going to actually stop here and we're going to turn this into a 2-part series on these surgical and anesthesia related questions. So we'll jump into the hypermobility hack. I promise I am going to cover those other topics that I mentioned at the beginning, but they'll be in part 2. So be sure to watch for part 2 that'll be coming up shortly. Okay, so today's hypermobility hack is also a bit of a teaser. I was trying to find the picture that I have from my surgeon of my Nissen fundoplication surgery because it's a really beautiful picture. And I realized that I have like my medical papers in a folder and it's not organized in a binder like I always tell my patients to do. We are going to talk about this in a future episode. Having a binder is really, really helpful. And I've had people say, well, why bother with a binder? Because my doctor's not going to look at all of that information. That is not the point. The point of a binder is that you can then pull out and reference important things when you need to have them. So you have easy access to, an encounter note or certain imaging findings or lab findings, etc. So watch for that in a future episode. And that is your hack for today. Start working on your binder. Okay, so that's it for today's episode. Thank you so much for all your fantastic questions. Please keep sending them in to bendybodiespodcast.com for the chance to be featured in a future episode. Thank you for listening to this week's episode of the Bendy Bodies podcast with a Hypermobility MD. You can help us spread the word about connective tissue disorders by leaving a review and sharing the podcast. This really helps raise awareness about these complex and multidimensional conditions. Did you know that I offer one-on-one support for both clients and healthcare professionals? Whether you're living with connective tissue disorders or caring for people who are, I've got your back. Check out my coaching and mentorship options on the services page at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, Twitter, or LinkedIn at HypermobilityMD. You can find Human Content, my amazing producing team who you got to meet today, at Human Content Pods on TikTok and Instagram. You can also find full video episodes up every week on YouTube at Bendy Bodies Podcast. We love bringing on guests with unique perspectives to share. However, these unscripted discussions do not reflect the views or opinions held by me or the Bendy Bodies team. Although we may share healthcare perspectives on the podcast, no statements shared on Bendy Bodies should be considered medical advice. Please always consult a qualified healthcare provider for your own care. To learn about the Bendy Bodies program disclaimer and ethics policy, submission verification, licensing terms, and HIPAA release terms, or to reach out with any questions, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.